A very good morning to all. I am Dr. A. Manoharan, Associate Professor of Pathology. Today, I am going to deal with inflammatory bowel disease. So, this inflammatory bowel disease patients usually presents with the complaints of a chronic relapsing abdominal pain, bloating sensations, a change in the bowel habits, usually stools at least 3 days per month or over 3 months, with improvement after defecation. This causes may be the inflammatory or idiopathic. So it's a chronic condition due to inappropriate mucosal immune activation. So the diagnosis of this IBD is predominantly of exclusive, and it always excludes infectious and other ischemic etiologies. The primary symptoms include bloody diarrhea of greater than 6 months. The two important diseases which comes under this category is Crohn's disease and ulcerative colitis. Both are the chronic relapsing idiopathic inflammatory bowel disorders. So this is the pathological mechanisms how the bacterial infections will causes the inflammation to the bowel systems. So the common etiopathogenesis or the genetic predisposition, and usually IBD1 locus on chromosome 16, which is present in the gene NOD2, whereas in ulcerative colitis, this is from HLA-DR2, and Crohn's disease is HLA-DR1 and DQ55 alleles. And immunology factors such as activated T cells and microbial factors, such as microbial organisms, which plays an antigenic trigger for the dysregulated immune system. And products of neutrophils and mononuclear cells causes tissue injuries and impaired integrity of mucous epithelial barrier and loss of surface epithelial absorptive function and activation of crypt epithelial cell secretion. These are all the triggering factor which causes the inflammatory bowel disease. Next, we move on to the specific Crohn's disease. This Crohn's disease occurs at any level of the alimentary tract from mouth to the anus. It is accompanied by iritis, uveitis, sacroiliitis, and migratory polyarthritis, etc. So it can occur at any age, and predominantly females are affected more than males. So morphology is 30% occurs in small intestine, 40% occurs in small intestine and colon, and 30% occurs in colon alone. And when it comes to the gross, it is a sharply delimited and usually shows the skip lesions. So it usually involves a typical transmural involvement, and it's a rubbery thick wall on barium X-ray, which we call as a string sign. So grossly it looks like a serpentine or linear fissure-like ulcers, which forms a fistula formation. So the mesenteric fat which covers all the surface, it looks like a creeping fat appearance. So this is a microscopic finding showing a haphazard crypt organization results from repeated tissue injuries and regeneration. And also you can see the non-caseating granulomas here, and there's a transmural Crohn's disease with submucosal and serosal granulomas. So which I discussed previously, microscopic finding shows inflammation, ulceration, distortion of architecture of glands, granulomas, fibrosis, and dysplasia in long-standing cases, which has an increased risk of carcinoma. So this consequences includes a fistula formation, obviously, then goes to abdominal abscess or some intestinal stricture. So what are the clinical features of this Crohn's disease? So usually this is an intermittent attack. There will be fecal blood loss. So because of this fecal blood loss, the patients will go for an anemia. There is a malabsorption of the B12, protein, bile, and fat. As previously explained, patient will be having arthritis, polyarthritis, amyloidosis, cholangitis, clubbing, uveitis, and nephritis. This Crohn's disease usually occurs in the colon, mixed into small intestine, and any part of the GIT. The important finding is a creeping fat, which is called mesenteric fat, wraps over it, It's called as a creeping fat appearance. It's more common in Crohn's disease. Here you can see, able to appreciate the middle portion of the thickened wall mucosa lost the regular folds, and the serosal surface is reddish, indurated adipose tissue creeps over the surface. The serosal inflammation leads to adhesions. The areas of inflammation discontinues throughout the bowel. So here you can be able to appreciate the small incisive strictures. Here you can see the linear mucosal ulcers and thickened intestinal wall. In this picture, you can be able to appreciate the perforation and associated serous inflammation of the mucosa. Whereas here you can be able to appreciate this fat, creeping fat appearance. So mesenteric fat wraps over it. Okay, it's called a creeping fat appearance. It's commonly seen in the case of Crohn's disease. What's the microscopic findings? Which I say the granulomas. So the transmural inflammation, which means the inflammation can access deep into the muscular layer, transmural inflammation. The inflammatory cells extends from mucosa to submucosa and muscularis and appears nodular infiltrates on the serous surface with pale granulomatous centers. Okay, so from mucosa it can extend deep into the transmural layer, forming a nodular infiltrates. Okay, this is a classical findings of a Crohn's disease. So granuloma is most commonly seen. Granulomas of Crohn's disease with epithelioid cells, giant cells, and lymphocytes. Special stains for organisms or usually negative. Organs commonly is H. pylori, which is negative. Okay. So for this only we have previously said the inflammatory bowel disease is predominantly of a disease of exclusion. Okay. So the characteristic finding of Crohn's disease are skip lesions, serpentine ulcers, serosities, string sign on berry membrane, and cobblestone appearance. Microscopically, we have mucosal inflammation with neutrophils and mucosal damage, ulceration, transmural inflammation, or non-caseating granuloma, which is the most important finding in Crohn's disease. So here we can be able to see a very clear picture of a Crohn's disease of terminal ileum, gross lesion showing a casus segmental intervening, okay, with the uninvolved areas called the skip areas. So you are able to see as uninvolved areas, skip areas, the bowel wall is thickened and the lumen is narrowed, okay, lumen is narrow, involved segment, this is the narrow, giving a host pipe appearance. Sometimes a serpentine ulcer, serpiginous ulcers is more common, okay. The deep fissures and swollen intervening several mucosa give you a cobblestone appearance, which is a common finding in a Crohn's disease. Okay, so cobblestone appearance, serpentine ulcers, escape lesions, serpiginous ulcers, which are the most common finding in a Crohn's disease. It's a gross appearance. Whereas it comes to microscopic, this is a Crohn's disease of ileum. The histological presence of transmural chronic inflammatory cell infiltration, deep fissures into the bowel wall, submucosal widening to the edema due to edema, some prominent lymphoid follicles, and few non-caseating epithelial cell granulomas in the bowel wall. It's a common seen in the Crohn's disease. So here you're able to see the skip lesions, and here also you can see the transmural inflammation, which is common seen in microscopic finding. So these are skip lesions of Crohn's disease. When compared to the other disorder of an inflammatory bowel disease, ulcerative colitis, whereas the involvement is a continuous colonic involvement beginning in the rectum. Okay, so this is how we have to differentiate between the Crohn's disease and the ulcerative colitis. Moreover, in Crohn's disease, in ulcerative colitis, we have pseudopolyps and intermittent ulcers, which is frequently seen in ulcerative colitis, which is lacking in the case of Crohn's disease. You can see these are all the normal area, skipped area. Okay, so this is an affected involved segment, which shows a cobblestone appearance, granuloma here, transmural chronic inflammation, formation of lymphoid follicle, thickened wall, okay, narrow lumen, sometimes causes some perforation, which is complications of Crohn's disease, perforation, abdominal abscess, okay, then linear ulceration, okay, fistula into the loop of small bowel, okay. So this picture alone can shows the total involvement of the Crohn's disease and its complications, okay. Can you able to appreciate all the diagrams easily? See, it denotes a transmural, which means it involves a muscularis propria and forms a granulomas with plenty of epithelial giant cells. So granuloma forms, which is a non-caseally granulomas, and the tube is narrow. It always shows the skip lesions. The involved segment showing a cobblestone's appearance. Okay. So once Crohn's disease persists for a long time, the complications or the consequence of this Crohn's disease leads to perforation. Okay, which is common for perforation. Sometimes of an abscess. Okay. This is how you'll be able to analyze this with the help of this diagram alone. So next we move on to ulcerative colitis. Ulcerative inflammatory disease, which is associated with migratory polyarthritis, uveitis, sacroiliitis. So it occurs at any age, peak from 20 to 25 years, and may develop into colonic carcinoma. So this ulcerative colitis has a high tendency in causing carcinoma of colon when compared to Crohn's disease. So gross findings, typically it starts in the rectum and ascends to the ileocecal wall. So which means it's a distal accentuation. So since it starts from rectum and ascends to the ileocecum, so this is termed as a backwash ileitis. Okay. So from retrosegment, it is affecting the ileum, rectum to the ileum. So it is termed as a backwash ileitis. So it involves continuous areas of the bowel, whereas in the case of Crohn's disease, it shows skip lesions. Okay, so here it involves the continuous areas of the bowel. It's a broad-based ulceration of mucosa, which is commonly seen in ulcerative colitis. And the most important finding is pseudopolyps. Okay, it's nothing but inflammatory polyps. Because of the excrescence of inflamed or damaged mucosa, this looks like a polyps, which are nothing but pseudopolyps. It's more common in the case of ulcerative colitis. Okay. For this ulcerative colitis, which involves all the segments of the colon. So it's called as a pancolitis. Obviously, it starts from rectum and goes to the ileum. So it calls a backwash ileitis. So it shows some linear ulcers. Whereas in Crohn's disease, we are able to see it causes a serpiginous ulcers. Whereas in ulcerative colitis, it causes a linear ulcers. So the colon gets inflamed, okay, much and enlarged. We can call this a toxic megacolon. So this is a total colectomy with pancolitis, showing active diseases with the red glandular mucosas in the cecum and a smooth atrophic mucosa distally. Okay. Diagram B showing a sharp demarcation between the active ulcerative colitis and the normal area, whereas showing the inflammatory polyps is nothing but a pseudopolyps, whereas segment D showing mucosal bridges. Okay, these are the gross diagram of an ulcerative colitis. So when we move on to the microscope, the most important characteristic finding of an ulcerative colitis is crypt abscess. Okay, crypt abscess. So plenty of dead-end neutrophilic cells are seen. Whereas diagram shows a pseudopyloric metaplasias, and C showing the disease is usually limited to the mucosa alone. Okay, does not enter deep into the submucosa or muscus layer. So it is limited only to the mucosal layer. Okay. So microscopic picture. Ulcerative colitis, which involves predominantly of mucosal layer, so it causes mucosal inflammation. So it involves plenty of dead and degenerated neutrophils. It's forming a crypt abscess. Okay, so it's a mucosal inflammation with the neutrophils. So predominantly damages the mucosa, causing ulceration. Okay, erosion of the mucosa causing ulceration. So there is no transmural inflammation, which means inflammation does not extend into the muscularis layer. And similarly, it shows a non-K-shaped. There is no non-K-shaped granuloma, which means there is no granulomatous cells, epithelial cells. Okay, epithelioid cells when compared to the Crohn's disease. So since it involves mucosal layer, there will be a more tendency for an epithelial dysplasia. Okay, which means the mucosal epithelial cells easily can go for dysplasia, which in turn go for an carcinoma in situ, which could turn go for a malignancy, carcinoma. Okay, so hence this ulcerative colitis has a high tendency to be converted to a carcinoma. So you should note the difference, important difference here. Okay, it involves only the mucosal layer, whereas Crohn's disease involves both, involves up to the muscularis propria. Okay, there we have a granuloma, it doesn't have a granuloma. But the epithelial dysplasia and tendency to convert to malignancy is high in ulcerative colitis when compared to Crohn's disease. So, what are the clinical features of ulcerative colitis? There will be an intermittent defecation and abdominal pain, blood and mucus passing the stools, loss of fluid, mucus and blood, altered bowel habits precipitated by stress. So mostly this ulcerative colitis is depends upon the severity and duration of disease. The severity depends upon the duration. Okay, so once if this prolonging for a long time, it is going. This disease is unnoted for a long time, or the patient doesn't have mind such a disease. It has a high tendency to convert to an invasive carcinoma. So, what are the laboratory findings of this inflammatory bowel disease? One is colonoscopy, number 2 is biopsy, and histopathological examination. So, this is a gross appearance of an ulcerative colitis. Here you can be able to see all the bowel habits, all the inflammations are involved. Ileums are colon, all types of colons are involved. Here you can be able to see the plenty of polyps, inflamed polyps. It's nothing but a pseudo polyps. So it shows a diffuse inflammatory infiltrate, crypt abscess, nothing but localized collection of polymorphic within the lumen of the industrial crypt with distortion of crypt architecture. Inflammatory pseudo polyps results of ulceration and healing with granulation tissues and regenerative hyperplasia. Muscles propria and serosa are unaffected. Overall thickness of the bowel wall is within normal limits. So these are important findings: diffuse inflammatory infiltrate, crypt abscess, inflammatory pseudopolyps, only muscles propria. It is not only mucosa, whereas muscles and the serosa are unaffected. Okay. Overall thickness of the bowel wall is within normal limits. These are the important characteristic finding of an ulcerative colitis. Okay. It also has intense inflammation at the lower right in the sigmoid colon and extends upward and around to the ascending colon. Inflammation continues along the mucosal surface and tends to begin in the rectum. The mucosa eroded shows only remaining islands of mucosa called pseudopolyps. So this is just inflammatory polyps. The pseudopolyps remaining mucosa ulcerated and is hyperemic. Okay, hyperemic. You can see the hyperemic areas. The pseudopolyps are as raised red islands of inflammation. You can see able to see the raised end of an inflamed surface. So this we can call as a pseudopolyp, just an inflamed polyps, inflamed mucosa. Okay, nothing but inflamed mucosa. We can call it pseudopolyps. Okay. Here you can see this ileocecal wall. Above this wall, you can see the beginning of mucosal inflammation with erythema and granularity. Okay, erythema and granularity. So the characteristic microscopic finding of an crypt abscess. So you can see plenty of degenerated neutrophils forming an abscess in the mucosal layer, which is a classical finding of an ulcerative colitis. Here there is a loss of architecture, microscopic loss of architecture of the in case of an ulcerative colitis. So the inflammation of the ulcerative colitis confines the mucosa. The mucosa eroded by an ulcer, which undermines the surrounding mucosa. Okay, here this is a mucosa. Here you can be able to see the erosion of the mucosa, showing an ulcer. Okay, so that's an intense inflammation of the mucosa. You can be able to see the plenty of inflammatory cells. Okay, the colonic mucous epithelium demonstrates a loss of goblet cells. You can see the loss of goblet cells, and exudate is present over the surface. Both acute and chronic cells are present. So this is an exudate. You can be able to see plenty of acute and chronic inflammatory cells. Okay, it's a loss of goblet cells. This chronic mucosa forms a crypt abscess. Neutrophilic exudate is in glandular lumens. The submucosa shows intense inflammation. The glands demonstrates loss of goblet cells and hyperchromatic nuclei with inflammatory ATPR. You're able to see abscess, crypt abscess typical with ulcerative colitis. Okay, plenty of crypt abscess. Okay, the classic finding of an ulcerative colitis. So this ulcerative colitis over time has a high risk of forming an adenocarcinoma. Here you can able to see normal glands. Here glands with the dysplasias. Okay. So it's a dysplasia with extensive nuclear stratification and marked nuclear hyperchromatism with irregular glandular arrangements. In the case of high-grade dysplasia, you can see irregular arrangement with loss of polarity. This is a colorectomy specimen, the high-grade dysplasia on the surface and underlying invasive adenocarcinoma is apparent at the bottom here. Okay, invasive adenocarcinomas, which is seen beneath the mucosa and surrounded by small invasive glands. Okay, invasive glands. So this is the difference between Crohn's disease and ulcerative colitis. Macroscopically, regions involves all GITs, colon and ileum, whereas ulcerative colitis involves only colon. The distribution, Crohn's has a skip lesions, whereas ulcerative colitis shows a diffuse involvement, where the structure, which is in the early stage, whereas ulcerative colitis at the late stage. So it's a thick wallop is very thick, whereas in the case of ulcerative colitis is thin, showing plenty of erosion of the mucosal layer. Dilatation of the wall is commonly seen in ulcerative colitis, and its microscopic inflammation. Microscopic inflammation is commonly seen up to the transmural layer in case of Crohn's disease, whereas it is seen only at the mucosal layer in ulcerative colitis. Pseudopolyps is more common in ulcerative colitis when compared to Crohn's disease. Ulcers, deep linear ulcers, which is commonly seen in Crohn's disease, whereas deep linear ulcers in ulcerative colitis, whereas serpiginous ulcers seen in Crohn's disease. Lymphoid reactions is more in the case of Crohn's disease. Granuloma is more common in Crohn's disease, and serosite is common in Crohn's disease. Similarly, fibrosis is more common in Crohn's disease. Fistula and sinus is more common in Crohn's disease, and adhesion is more common in Crohn's disease. So, malabsorption of fat and vitamin is seen in clinically seen in the case of Crohn's disease. So, malignant potential, it has both has a malignant potential, but a high risk than ulcerative colitis. And in response to surgery, so in the case of ulcerative colitis, is a good prognosis when compared to Crohn's disease. This I already shown you. You got plenty of skip lesions in case of Crohn's disease, whereas ulcerative colitis, but the continuous chronic involvement is seen here. So here we can see a pseudopolyp in case of ulcerative colitis. I have a linear ulcers, whereas in case of Crohn's disease, you have a serpiginous ulcers. Okay. This is a difference between the Crohn's disease I described previously. Okay. So important some other findings, perianal fistula, which is more common in Crohn's disease when compared to ulcerative. Malabsorption as already discussed. Malignant potential, the chronic involvement alone, it is common. Recurrence of surgery is common in Crohn's disease, whereas ulcerative doesn't have any recurrence of surgery. So toxic megacolon, which is more common in case of ulcerative colitis. Toxic megacolon. Okay, can you have to appreciate the gross picture? So you can see the enlarged, inflamed colon is called as a toxic megacolon with the gangrene. You can see a greenish appearance. It's called a gas gangrene. So thank you, students. So today we have discussed about the inflammatory bowel disease. So the most important thing is there are two types of disease. One is Crohn's disease and ulcerative colitis. Okay, you need to know the important difference between the Crohn's disease and ulcerative colitis. And Crohn's disease, it shows skip lesions, and whereas ulcerative colitis shows multiple pseudopolyps. Okay, whereas skip abscess is seen in ulcerative colitis. Okay, but malignant potential, both have malignant potential, but progress is good in ulcerative colitis. Okay, thank you, students. Thank you for this. Thank you.